I'm Dr. Arnold Wheel, and I practice in Atlanta, Georgia. I practice non-surgical orthopedic medicine and pain management. Today I'm going to be talking to you about pain management, in particular the anatomy of injuries. As you know, chronic pain is very common and prevalent within our society. It affects more than 50 million Americans, and it's associated with a lot of different comorbidities, which makes it even more difficult to treat. These comorbidities can be things such as anxiety, depression, sleep disorders, and in fact, a lot of the medical costs associated with chronic pain is not only from treating pain itself, but also dealing with some of these comorbidities. And the financial impact is staggering. It's almost $80 billion annually. Chronic pain affects a large percentage of our population, and more than 40% of patients that do have chronic pain statistically are treated inappropriately or inadequately for their pain. Musculoskeletal pain is probably one of the most common types of chronic pain that we see in private practice. The prevalence of chronic pain in this population is between 15 and 30% and accounts for about 1 in every 7 patients visits to primary care physicians. And again, it affects 1 in every 3 Americans. More than 50 million Americans are affected, resulting in over 325 million physician visits per year. That's a lot of visits for chronic pain. The impact of chronic pain is staggering, and again, over 50 million Americans seek treatment annually for chronic pain conditions. Nearly 25% of these patients that actually have chronic pain change healthcare professionals during the course of their treatment. And this is fairly significant. And the main reason why they continue to change healthcare professionals is because they feel like they're getting inadequate pain treatment. There's really a need for a more multidisciplinary approach to treating chronic pain. But often in our communities, what we see are quote, pain clinics that really focus on one area of treatment. For example, there's a lot of so-called pain clinics that all they do are injection therapies. There's other pain clinics that really focus on medications. And then the treatment of chronic pain really encompasses a multimodal approach, including injections when necessary, pharmacologic intervention, and oftentimes other types of therapies like physical therapy, occupational therapy, and of course exercise for strengthening and stabilization for long term. So again, all these factors really come into play and are important in preventing our patients from jumping around from doctor to doctor and sticking with one pain care professional. So there really is a need for understanding of this global impact of chronic pain, and again, how it affects not only our society, but how it affects the patient that actually has chronic pain. So we talk about pain. I always like to emphasize there's a difference between acute pain and chronic pain. And really in my practice, we see orthopedic injuries and we see a lot of acute pain as well as chronic pain. So every patient I see, though, comes in complaining of some type of pain, so I'm always doing pain management. But there's a difference and a different approach in whether we treat acute pain versus chronic pain. Acute pain is defined as pain that comes on quickly, it can come on after some type of injury or trauma. It can be severe in nature, and it can come from different sources. It can be from a nociceptive type of injury that may cause pain. It can be from a post-operative procedure. But typically acute pain is self-limited, tends to go away with proper treatment over a short period of time. Now it's different than chronic pain. Chronic pain is really acute pain that gets out of control and doesn't respond. Chronic pain is pain that persists for an inappropriate or a prolonged period of time. A lot of providers get hung up on, well, 3 months is less than 3 months is acute pain, more than 3 months is chronic pain. But I don't really like to define pain, acute versus chronic, based upon a numerical value. There is kind of the accepted 3 months or greater, it's developing chronic pain. But, I really like to think of pain that's chronic as pain that, is really persisting longer than you expected it would. So for some injuries, you would expect the pain to resolve quicker. And when it doesn't, continues to persist, that's when it's becoming chronic, and that's when we really have to intervene to try to treat it aggressively to keep it from becoming a chronic painful condition. But typically, chronic pain develops over time. It lasts longer than expected, and again, it's associated with a lot of the different comorbidities that I mentioned before, and I'll talk about later on. Let's talk about pain. And again, most of chronic pain tends to fall within the musculoskeletal pain syndromes. Again, musculoskeletal pain is very common, probably the most common type of pain that we see in an orthopedic setting. So the most common musculoskeletal pain syndromes are those associated with the low back, and we can talk about low back pain and all the different areas of low back pain and how that's affected. Myofascial pain, soft tissue pain, often associated with muscle spasms. Cervicogenic pain and headaches, very difficult sometimes to treat headaches. It's a very complicated a medical condition that can present with a lot of pain. It can become chronic. Cervical dystonias and spasticities. These are the types of musculoskeletal pain syndromes that often cause acute and chronic pain. Now, back pain, I like talking about back pain because that's the majority of what I see and really specialize in. And back pain is very tricky. It's not as straightforward as a lot of other medical disorders that we see, especially in a primary care setting. The challenge with back pain is that there's a lot of causes of back pain, and there are multiple anatomic sources that can actually contribute to the back pain. And I'll talk about some of those today. And in addition to the multiple anatomic sources, there really is no standard method for categorizing, diagnosing, and really how we treat pain syndromes. And I'm sure if you look in your own communities, you could probably identify 4 or 5 different practices that treat back pain, and many of them may have different approaches. And again, I'll talk about some of the approaches, but the treatment protocols tend to vary from rest, exercise, to physical therapy, spinal manipulation, oral medications, injections, and in the worst case scenario, of course, surgery. So there's a lot of different approaches. There's no standardized algorithm, no standardized treatment, and it makes back pain much more challenging because you really have to dial down and get your diagnosis and be an accurate diagnosis before you can really start to treat. Another type of pain, very common, we see this in practice all the time, is myofascial pain. Myofascial pain is really soft tissue pain. We really are talking about trigger points and pain, tight areas of muscle bands that cause pain. And again, the diagnosis hinges on these painful muscle trigger points. And the trigger points are active trigger points that produce persistent pain. So for example, when we press on a trigger point is an area of muscle, a hypertonic area of muscle that when you palpate or press on it, it radiates pain into a very well-defined area of the body. So for example, trigger points in the neck, when you palpate that area, it would cause pain in a very consistent pattern, and that's a trigger point. And they can be active where it produces pain on a persistent basis, or the trigger points can actually be latent, and so there's no pain unless that area is really palpated. And there's a lot of different treatment approaches to trigger points and myofascial pain, ranging from medications, in particular muscle relaxants, anti-spasticity medications, and then also trigger point injections, soft tissue release, myofascial release, and physical therapy. Now, talked a bit about cervicogenic pain and about headaches. Cervicogenic headaches, very common, especially after an acute traumatic injury like a motor vehicle accident, some type of flexion extension accident. Again, the headache typically will originate in the tissues of the neck. It can be caused by injuries such as cervical spine, again like a whiplash injury or a fall. And again, there's lots of different approaches to the cervicogenic headaches, from medications, different types of medications, to different types of therapies, again, to different types of injections. So we'll talk about some of those as well, but what you're seeing is this common theme of soft tissue pain treating with a combination of medications, physical therapy, and often different types of injection procedures. So now that we've talked about some of the causes of pain, in particular chronic pain, how do you assess the patient? And that's really the key. And as physicians, when I talk to physicians about chronic pain, the first step I like to really emphasize is, the most important aspect is really the collection of all the information. Obtaining a history and reviewing the medical records. And a lot of times, by just talking to the patient and really focusing on the history, you can get enough information that can really give you your diagnoses. I'm not saying you don't have to examine the patient, because that's certainly a very important part of the evaluation also, but the history is vital. So collecting the data is something that a lot of times physicians don't pay enough attention to. In particular, pain history. Again, we're talking chronic pain patients, so they're really focused on their pain. How long has the pain been there? When did the pain first start? Okay, what types of things have made the pain worse over the years? What types of things make the pain better? Again, all the factors that impact that pain are important to know for us to have a better idea of where the pain's originating, but also how we're going to go about treating that pain. So again, collecting the data, finding out about the history, both chronologic and also the intensity and nature of the pain, very, very important. Then defining the pathophysiology. It's too easy, and all the time I see somebody comes in with pain, and physicians tend to just start treating the pain without really having a good understanding of where the pain's coming from. All right? Not really very effective from a long-term perspective. So the next step really is to define the pathophysiology. Let's take back pain, for example. Back pain, as I said, it can have multiple anatomic sources of back pain. It can be pathophysiology, it can be in the intervertebral disc, it can be in the bones and joints, it can be an inflammatory process, it can affect the nerves, or it can be strictly muscles and soft tissue. So knowing the pathophysiology, knowing where the problem lies is really important, because if it's a disc problem contributing to back pain, contributing to chronic pain, then my treatment is going to focus on correcting the problem, which has to do with the disc. So I'm not going to be as focused. We don't want to just treat the symptoms. I need to really define the pathophysiology, know that it's intervertebral disc, and treat the disc. If it's muscular, my approach is going to be different. For example, I'm going to select different types of medications to use in this patient than I would if it's a disc problem. So again, defining the pathophysiology is very important to determining the approach to treatment that you're going to make. Once you have obtained all this information, integrate the findings. What I mean by that is we know the pathophysiology, we have an understanding of the pain, the intensity of the pain, how it affects this patient's life. We need to put it together. We need to know the mechanism of the injury, and this will help us then to develop a therapeutic strategy. This will help us then to develop a therapeutic strategy on how we're going to treat our patient and how we're going to jump in and try to attack the chronic pain. And again, I said in the beginning, it's a multi-modality approach. So we're not going to focus on just injections or just throwing a bunch of medications at the patient or just sending them off to physical therapy. Again, it's a combination of all the above. It may include some medications, it probably will. It may include physical therapy, although for chronic pain, the indication of physical therapy is not on a long-term basis, but for very specific, well-defined periods of time, depending upon the type of pain. And then finally, in some instances, chronic pain, when they have acute exacerbations or certain types of pain that we need to address more suddenly, we'll consider therapeutic injection procedures, and I can talk about those as well. Okay, so I mentioned defining the pathophysiology of the pain. Let me illustrate why that's important. As you can see over here, we have an example of neuropathic pain. Neuropathic pain is a very specific type of pain where there's an abnormal processing of the sensory input by the central nervous system or in the peripheral nervous system. So this type of pain, neuropathic pain, really involves the nerves. Right? So what happens is an altered structure and function of the nerves, and this can be caused by some type of damage or lesion in the nervous system. Nonetheless, our treatment approach to neuropathic pain is going to be much different. For example, I may be less inclined to use opiates to treat pain and more inclined to use some of the medications that really are very effective and been shown to be effective for neuropathic pain, such as Neurontin, Cymbalta, or Lyrica. Those are some examples of drugs that really are targeting much more neuropathic painful conditions. Nociceptive pain, again, pathophysiology may be from a localized tissue damage or injury. For example, patients that have had trauma, localized trauma, burns, or arthritis, myofascial pain, all these are examples of a nociceptive type of pain. The pain is very localized to a specific area in the soft tissue or the bones. Again, what happens is there's a stimuli that damages the tissue, okay, and this irritates the specific nerve endings or areas and causes inflammation. So this nociceptive pain can be very localized, and again, our treatment approach is going to be different. We may do some trigger point injections, may try very focused physical therapy, exercises, and if we use medications, we wouldn't use neuropathic type of medications, but instead may use medications that help with inflammatory process, with muscle spasm, etc. So again, defining the pathophysiology is very important on how we decide to treat our patients because, again, it's going to dictate our approach. And finally, I have just two examples here, again, of inferred pain pathophysiology because you're not going to see the pathophysiology in these examples. But there are many cases where we have patients that come in complaining of severe pain, and when we really focus in on trying to define the pathophysiology, we may see that it could be psychogenic pain. And I had a very good example of this many years ago. I had a patient who, it was about a 21-year-old gentleman who came in convinced that he had fibromyalgia as a cause of his chronic pain. He had a lot of pain, had been to see many pain physicians around the Atlanta area. As you know, fibromyalgia is a disorder that can be very severe, but it's very common in females, especially in the 45 to 55-year-old age range. So he didn't even really fit the category. But to make a long story short, I didn't feel comfortable giving him opiates. He was requesting very specific opiates for his pain, which he'd been getting on an ongoing basis. And I really realized early on there was something wrong with the picture. And when I really dialed in and went into a lot of research on trying to analyze this pain, it became apparent that his pain was more of a psychogenic nature. I sent for a lot of psych evaluations. I did some other types of psychometric testing on him. And, just to be, complete and thorough, we had obtained lots of different diagnostic studies, such as MRIs and CTs and EMG nerve conduction studies, and everything was normal. He really didn't have a pain generator except for the psychogenic component of pain. Now, the reason this is so important to figure this out is because I could have just taken the easy way out and said, okay, chronic pain, you say you have pain, we don't see anything, but I'm going to treat you for your pain. And I could have started just giving him opiates and for years and years fed the opiate craving that he had and just treated him as a, quote, chronic pain patient, giving him opiates. Or I could have taken the other approach of the, quote, pain clinics that are really injection focused and just start doing injections on him on a regular basis, trigger point injections or epidural injections, and just done injection after injection after injection. However, by really recognizing that the pain was psychogenic, it really made all those treatment modalities I just mentioned really inappropriate because there would no need to do injections because the injections would not really affect anything that's causing his pain. There'd be no need to give him opiates because he really didn't have a specific entity causing his pain. So our treatment approach, while it entailed medications, was a non-opiate class of medications and a different type of approach. So again, from the perspective of being a case manager or an adjuster or looking at the picture not from the eyes of a practitioner or provider, but from the other side, you can see how it's important then to really feel comfortable that your client, and in this case my patient, is really being assessed and treated appropriately because a lot of unnecessary things could have been done in this case. We've now talked about some of the anatomical considerations. I've discussed some of the, again, pathophysiologies that we see associated with back pain. And I touched on, how we have to integrate all these together to then help with our assessment. So we've talked about integrating the findings, in particular comorbidities. I said early on that one of the challenges in treating chronic pain, especially chronic back pain is a good example, is that the pain is there, and that's why the patients come see us as a physician because the pain is present and they really want something to be done for their pain. But often, that's a part of the problem. There's a physical or a medical phenomenon that exists, and we can address that and treat that. But there's also this psychiatric or sometimes psychosocial pain, for lack of a better word, that exists also. And a lot of times with chronic pain, it's very common and certainly not out of the ordinary. We see depression, anxiety, problems with sleep. Okay, all these things tend to occur with prolonged constant pain. It's very well cited in the literature, but what happens, it becomes very, very difficult then to focus just on the pain and not these other comorbidities. Because if you ignore some of the other issues that I've mentioned, the patient's still going to have problems and still not really recover as fully as they might. Okay? So all these things have a negative impact on the immune system. That's why we see our chronic pain patients tend to be more prone to infections, to getting sick, and again, lots of other things down the road that then cause greater expense and decrease function as far as the individual. So our goal then is to treat the pain, not just put a Band-Aid on the problem, but try to really understand and address the problem causing the pain, and then treat all these other comorbidities. Recognize if there's depression, treat the depression. A lot of times that's pharmacotherapy. If there's anxiety, address the anxiety. If there is problems with sleep, a lot of the patients that have chronic pain, they won't tell you they have problems sleeping, but they do when you question them. But what's helpful is a lot of the medications that we use for these chronic pain patients actually have a positive effect on sleep and help them establish more normal sleep patterns and get better quantity and quality of sleep. So our goal then is to treat the pain, but also treat some of these other comorbidities. Our assessment then, as we are continuing to go down through our assessment, a lot of times we want to establish a work history, and that's really important. A lot of our patients want to be able to function, want to be able to get back integrated into society. Again, what we really focus on in treating pain is the pain and quality of life, improved quality of life. It's not reasonable necessarily to expect in the part of the patient or the physician that I'm going to get rid of all the pain and make somebody pain-free. When someone has chronic pain, they obviously have some pathology that's persisted for quite a long period of time. And so our goal really is to maybe reduce the pain, get the pain to a manageable level, help our patients learn to cope with their pain, modulate their pain, but really improve their quality of life, meaning able to go back to work, types of things they can do with their family, types of things they can do around the house. We really want to address all these issues. So we look for then in our assessment red flags. And what I mean by that is we've assessed the patient and we're giving the patient the benefit of the doubt, but a lot of times we want to make sure that we don't see something in this evaluation that maybe we should. So in looking for red flags, we look at work history. After an injury, the patient ever return back to work or make an attempt to return to work? Are there inconsistencies either in their symptoms they're having or on their physical exam? And a lot of times in assessing a chronic pain patient, a classic example is the patient that got injured at work. There's no witness to the injury. They have a low back injury. And over the course of maybe 1 or 2 years, they've been to multiple physicians. They have had MRIs. They've undergone many epidural injection procedures. They've been to physical therapy. They've been out of work. They have an attorney. And so now they're coming to see me. And again, what is asked of me is to evaluate the patient, to do an independent medical evaluation, and give my opinion on what's causing their pain, has the treatment been appropriate, and is the patient at maximum medical improvement. But during the course of my evaluation, sometimes I see these inconsistencies on exam. For example, many years ago I had a patient who came in the office, the very same scenario with a back injury and not been back to work, chronic pain. And he literally walked into my exam room almost dragging his leg. So I evaluated him. I did some testing in the office. During my examination, I noticed some inconsistencies. For example, during straight leg raise test, it was negative while the patient was sitting at the table and I was talking to him. But when I had him lie down on his back and did straight leg raise test, he almost jumped off the table screaming. So inconsistency right there. But what I did notice is when I finished my evaluation of him and told him he could leave, actually watched him walk out of the office. It was raining outside, or drizzling, not really raining too hard, but drizzling, and he actually sprinted to his car. This is an example of an inconsistency on exam. What I witnessed after the exam was very inconsistent with what I saw in the treatment room. So again, these are important things to consider in doing our assessment because, again, it may affect lots of things from our treatment or what we would not do for treatment to really recognizing if this patient is at maximum medical improvement. At that point, I was pretty convinced that he was, and the integrity of his complaints really came into question. Also, patients that miss a lot of physician appointments. I see this on occasion. They cancel their appointment. They don't show up. Again, somebody that's truly in pain, chronic pain, the legitimate pain patient, they're not going to miss their appointments. They're going to show up at their appointments, and they're going to be compliant in their treatment. And finally, the last red flag, pharmacologic. We see this a lot. The standard in pain management is really the use of long-acting, sustained-release opiates for chronic medication management. And so the old adage of, treat pain, acute pain with all the short-acting opiates, Vicodin, Lortab, Percocet, that's really not accepted today. Today we use longer-acting agents that have usually are taken once or twice a day, or a patch that can be changed every 3 days. And these medications provide a more steady state of the plasma concentration of the particular medication and allow for better pain management and pain control. So again, patients that come in requesting a specific type of medication or for some reason they keep losing their prescriptions, that's a red flag. And again, in our chronic pain assessment, that's something we need to be very aware of and look out for. So we have this integrated approach then to pain management, and that's really what I've kind of been driving toward so far. Again, our assessment is comprehensive, but our focus is on not just our diagnoses and determining the pathophysiology, but really on educating our patients on what's going on, what they can do to prevent their pain or kind of mediate their pain, and the things they need to know so they can live their life, hopefully a better quality of life. So again, our pain management approach is going to be based on appropriate diagnostic testing. Not every patient needs an MRI. CTs are not the best test of choice to look at a herniated disc. So the appropriate diagnostic testing is important. There are certain types of diagnostic tests that are more helpful and beneficial in assessing our chronic pain patients and in managing our patients as well. And then, of course, focusing on non-surgical options, which is really what pain management is. Pain management is not a surgical specialty. It's a non-surgical specialty, and our focus is on non-surgical options, again, to alleviate the pain, help the patient manage their pain, address the comorbidities, and hopefully improve the quality of life of our patient. So the intervention of pain or pain intervention is very important. That's why the patient's there, that's why we're there, and that's really the foundation of our treatment. Anatomy of the spine. This is where it really becomes important to have a basic understanding of the anatomy of where the pain may originate and the anatomic considerations that may affect that. So I like to be very basic when I talk about pain and pain generators. And again, look at the anatomy of the spine. By focusing on the anatomy of the spine, understanding the spine anatomy, you can really get an idea of the source of the pain. Is it muscle or is it disc? Okay, is it a bone or a joint problem? I mentioned previously it could be more of an inflammatory process. Often it is more of a nerve type of pain or a nerve injury. So these are very important to determining the source of the pain. And then again, pain generators. Where's the pain coming from? Is it coming from a nerve? Is it coming from the disc? Okay, so we'll talk about that. And then the anatomic considerations in our assessment of pain. So I've mentioned several times, specific about back pain, looking at the source of pain. Again, I've highlighted that it could be disc, it could be bone or joint related, muscles or ligaments, nerve roots, or an inflammatory process. And if you look over here, this is a very good example of why it's important to really have an appreciation, understanding for the pain generators. You can see in this illustration that there are areas where the pain can originate from, whether it's the neuroforamen, where the nerve exits the spinal canal, whether it's the intervertebral disc, which can account for pain, and you can see labeling of the disc here, or if it's in the interarticular facet joints, the zygapophyseal joints. Again, there's pain generators in that area as well, and that can account for the patient's pain. So by understanding the anatomic considerations, in particular of the spine, you can get a better sense and appreciate where the pain may be originating from. And here's just another example of an intervertebral disc. You can see here the inner nucleus of the disc. It's referred to as a nucleus pulposus. And the disc itself is surrounded by these annular layers of fibrous annular rings that really give the disc the integrity and strength of the disc. So again, looking at the disc, and this next slide is also a very nice illustration. And what this illustrates, you can see the intervertebral disc here, but how close it is to the nerve root. You can see the nerve root in yellow. And you can see it doesn't really take much for an irritation of that nerve root from the disc, whether the disc may physically compress or pinch the nerve, or whether it just may become inflamed. That inflammation in the tissue can then chemically irritate the nerve. So really appreciating the close relationship between some of the structures in the spine can give you a better appreciation for the symptoms the patient may have. So even though, and this is a good example, even though you may be sitting there looking at the medical records, you may be looking at the MRI and say, wow, this MRI is negative, but this doctor is treating the patient for sciatica, it really can make sense, because even though the disc may not be herniated, there may be so much inflammation around that area. That inflammation can then chemically irritate the nerve root and cause pain down the sciatic nerve distribution. So again, the close relationship between the nerve root and the disc, and even the soft tissues and muscles, can account for some of the problems and some of the complaints and some of the chronic pain conditions that we see in our patients. So, what are some common symptoms associated with back pain? And I've kind of alluded to that already. Besides just the low back discomfort and pain in the low back, we often see sciatica or leg pain, and the previous slide showed you why that may occur, the close relationship between the nerve and the disc. Muscle spasms is very common. I would say over 95% of all patients with back pain have a component of muscle spasm. So it makes it very important and really very imperative when we're treating back pain to treat the muscle spasm as well, because there tends to be this spasm cycle that occurs, and unless we really address the muscle spasm, we're not going to be as effective in our treatment. Also, patients with low back pain can have pain radiating at the hip, the buttock, or the groin. Again, depending upon the level of a disc bulge or herniation, a level of a disc irritation can affect whether the pain radiates into one of those particular areas. Many times patients will have numbness and tingling down their legs, sometimes all the way to the foot. Again, this is a direct result of irritation of the nerve root, which you saw previously, and that can cause these nerve-type symptoms. Not just numbness and tingling, but also weakness, motor weakness. And again, the nerves are made up of sensory fibers and motor fibers. So if there's irritation of a nerve, be it a physical compression of the nerve or a chemical irritation of the nerve, patients can present with weakness, and we see that not infrequently. And then other unusual symptoms. And by that I mean, patients come in a lot of times with different complaints, some of them legitimate, some of them not quite so legitimate. And, it's our job, and I like to make it my goal is to determine whether some of the things they complain of are really possible or not. So, again, a lot of things can occur with back pain, but the most common, pain in the low back, sciatica down the leg, some numbness and tingling, and occasionally motor weakness. All right, so let's talk about the physical exam then, because we've really kind of worked all our way through our assessment, our diagnoses, and now we're really going to focus on the exam. The exam is, to break it down, really consists of 4 main areas in the chronic pain patient: an orthopedic assessment, a neurologic assessment, a psychologic assessment, and then a functional assessment. Now, I'm not implying that each of these you have to do a lot of extensive and very demanding types of tests, but again, orthopedic assessment, pretty simple. We're going to look at the structure of the spine. We're going to look at the bones throughout the body. We're going to look at the joints. We're going to assess for any joint pain and joint abnormalities. We're going to look for crepitus on exam. We're going to do simple things like palpation over joints, palpation over bones, range of motion. All the components of the orthopedic exam, they're going to tell us that there's not a fracture, there's not a tumor that we can see, there is no specific orthopedic abnormality that may account for their pain. Next step is to do a neurologic assessment. Again, test the cranial nerves, do testing like straight leg raise tests, look for nerve root tension signs, all these things that we can verify there's no damage to the nervous system. Some patients that have a really bad disc rupture may develop what's called cauda-equina syndrome. This is a very serious entity. They may have loss of bowel or bladder control. So again, assessing the neurologic system, sometimes doing a rectal exam to determine whether there's any change in the tone of the anal sphincter in some types of very traumatic spinal cord injury cases, very important. So typically we will assess the reflexes, we'll assess the motor and strength of the patient, we'll do a sensory exam, and then we'll assess gait and briefly assess the cranial nerves. All right, then we can get a good sense of whether there's any damage to the nervous system. In some cases, in particular of chronic back pain, it's necessary to do anywhere from a brief to a more thorough psychologic assessment. Oftentimes, and I've said this before, we see patients with chronic pain and there's some psychogenic component or maybe some psychological overlay. Not uncommon, but in more severe cases, it's imperative then to do a very thorough psychologic assessment to see, how much of that is really affecting pain. Because then again, they may determine your treatment, that may have an impact on your treatment. And finally, the fourth component is really a functional assessment. What the patient can or can't do. Are they independent in their activities of daily living? Can they take care of themselves? Can they dress? Can they do what they need to do to get through the day? Can they drive? Can they work? Can they stand? All these things are important to not only question the patient about, but to try to observe and see them do these things while they're in the exam room. Again, there are a lot of different anatomical sources of injury. The history and examination is very important. Diagnostic testing is really key, and that's something I'd like to touch on now. And then finally, treatment. Treatment, again, is really the focus of our pain management. And it can become surgical, but we like to really focus on the non-surgical component. Briefly, I'll talk about the diagnostic evaluation in treating pain, because really we try not to get too far down the road in this. I mean, the patient has had pain. Many times we see these patients with chronic pain. They've already been through the diagnostic assessment component. But again, to just review that, we have the most common things that we will see or utilize in our evaluation: X-ray, MRI, CT, electrodiagnostic testing such as an EMG or nerve conduction study. And not so often bone scan, but certainly in certain types of pain, such as a sympathetic-mediated pain, that may be helpful. And then finally, lumbar discography to really assess the disc. So I'll briefly show you some examples of these and give you an idea of why we may use them. X-ray is really one of the most common types of diagnostic tests that we utilize. It's very quick, very easy to do in the office. We can see whether there's a traumatic injury, such as a fracture or another type of abnormality on X-ray film. Again, we can evaluate that acute injury. We can do it very quickly. It's not an expensive test, and it's easy to do. And we can also see whether there may be degenerative conditions that are there, and often those are pre-existing problems. And there's minimal radiation exposure with X-rays. I mean, people always worry about the radiation from an X-ray, but it's very small. And unless they had repeated X-rays every day for an extended period of time, there's really not a lot to worry about with a routine X-ray. And this is an example here of an X-ray with some, you can see the black arrows denote some very degenerative changes in the spine, some osteophytes forming. And so this is an example of how an X-ray may be helpful, because we can see pre-existing degenerative problems. We can see also if there were a fracture, which there's not a fracture in this particular example, but would be able to identify that very quickly. And we may not have picked that up on exam. I've seen many, many patients who can't really tell they have a fracture by examining them. They may be tender, but it requires an X-ray to really determine that. The next diagnostic test is an MRI, and I'm sure you're very familiar with MRIs. They're probably one of the most common diagnostic assessment tools that we utilize, and they can be very valuable. They can give us images of the internal structures that are responsible for the pain. I mean, we can see on an X-ray, we can see the bones, but really we can't see a lot more than that. The MRI gives us the ability to see a lot of the structures and soft tissue that we don't see on an X-ray. Discs, nerves, muscles, soft tissue. It's a non-invasive procedure, and it's very sensitive diagnostic test for structural damage. So we can actually see if the disc is herniated. We can see if the disc is compressing on a nerve root. We can see sometimes if there's a tear in the disc, in the annular layer of the disc. Now, on the negative side, it's a more expensive diagnostic test. The patient's got to be able to go into the MRI tube and be pretty immobile and pretty still for anywhere from 45 minutes to an hour. And again, if we're concerned about an injury to the bone or joints, it's not as specific or in some cases sensitive for those types of injuries. However, in looking at disc problems and low back problems, MRI sometimes can be an invaluable tool to really help us determine what we may consider doing next. Here's an example of an MRI, and you can see here very well we were able to pick up a spinal tumor on this MRI. And you can see very nicely the intervertebral discs that are interspaced between each vertebral body, and the spinal cord shows it very well, but you can see that very well-defined tumor in the spinal canal. So MRI can be an extremely important type of diagnostic test to look for some of these entities that would not be apparent on a routine X-ray. Computerized tomography, or CT, is a type of, again, advanced diagnostic test. It's often done with myelogram. Again, it's an excellent tool for evaluating bones, but also utilized a lot for patients who may be surgical candidates. And we can really see whether there's spinal cord encroachment or whether the spinal canal is being compromised due to fragments of bones. It's a very quick and inexpensive test compared to an MRI. But again, the problem is it's not a good study for soft tissue, herniated discs, or muscles. A lot of times I've seen ER physicians or these emergent care facilities, and they send patients for CTs when they have back pain and leg pain. Really not the best type of diagnostic test. I mean, a computerized tomography, especially when utilized with myelogram, is really more valuable for surgical types of patients. And again, patients are looking really for a fracture that may not have shown up in a routine X-ray. But if you're thinking about a disc, a nerve, or these soft tissues, you really want to stick with an MRI. Here's an example of a CT. You see very well the bone. You can see the joints very well, the facet joints. And again, can't really see the disc, can't really see the soft tissues as well as we'd like. So this type of examination is really more effective in looking at bones and looking at the osseous structures. The next diagnostic test is referred to as an EMG and nerve conduction study. It's electrodiagnostic testing, again, looking at the nervous system and the nerves. Okay, and what we do, we bring the patient into the room, we tape some electrodes across the paths of very specific particular nerves, depending on where we're testing. We, with a little device, can give a stimulus to the nerve, and then we measure the speed of the nerve transmission. And what we're able to do is really assess if there's a lesion in the nerve, where is it? If there's nerve damage, where's the nerve damage? How long has it been there? Is it new? Is it old? Is it getting better? Is it getting worse? Is it healing? And these are very important things that we often want to see, especially in a more chronic patient. We can determine, okay, there's nerve damage, so we need to do this. There's no nerve damage, so we can be a little more conservative in our approach. And the EMG nerve conduction test can be very valuable, sometimes to get a baseline of where we're at, or prior to surgery. Many times surgeons, especially with carpal tunnel, for example, will want to have an EMG to document the nerve lesion. And this is just an illustration, or a picture actually, of an EMG machine. You can see the graph very nicely, what a normal nerve conduction with medial and distal latencies may look like. And again, not to get too specific, but basically it's a good test to look at the nerves, invaluable test often in determining whether there's nerve damage. And we can pick up things on the EMG that you just can't see in an MRI, a CT, an X-ray, or even by physical exam. Finally, discography is another great test. Again, the focus is a little different. In the previous examples, we've looked at bones. We've looked at images of the soft tissue, pictures per se. We've looked at the nervous system, a more dynamic test. Again, the EMG is looking at real time of the nerves. Okay. Discography is another type of evaluation, looks at real time of the disc. And this is a dynamic test that really assesses the intervertebral discs in the spine and give us a lot of information. If we know the patient has discs that are herniated at multiple levels, and we see that on an MRI, but they've not gotten better with our treatment, which may have consisted of physical therapy, medications, injections, and it doesn't really appear that they're a surgical candidate because the MRI is not really a surgical MRI. A discogram is a great test, a great diagnostic tool to use at that point. It'll tell us, of those discs that are herniated, which disc is actually causing the pain. Where is the pain generator? And then what is wrong with the disc? Does the disc have a tear in the annular layer? Or does it have a no tear? It's a contained herniation, but that is causing pain by compressing or irritating a nerve structure. So the key here is being able to identify which disc is involved and what that disc, what the problem with the disc is. And this allows the physician then to direct the appropriate treatment to the correct disc. And I'll show you in just a moment an illustration. But again, there are really two options here. Either the disc itself has a tear in the outer layer and chemicals are leaking through there, or it's contained herniation, and we know that that's what's causing the pain. So we can then differentiate between the need to repair the annulus of the disc or decompress the disc using a different type of procedure. So this gives valuable information not only to the surgeon, but also to the non-operative physician in trying to treat the pain. Here, in this picture, you can see an example of a discogram, and you can see the needle going into the lower disc. And when the dye is injected into the disc and the disc begins to fill up, you see some of the dye actually leaking out of the disc. We know by doing this and seeing this particular pattern, that disc has a tear in it. That disc has a hole and material is leaking out of the disc. At the same time we injected this disc, we got the pressure inside the disc, and we also reproduced the patient's symptoms. We reproduced their back and leg pain. So we were able to determine then, this is the painful disc, and this disc has a tear or a hole in it, and that's what the problem is. All right, so that gives us good information, dynamic information on how to treat our patients. So the cost then of these procedures, we've talked about X-rays, I've talked about CT, MRI, I've talked about EMG nerve conduction test. Discogram, again, is a little more invasive, and certainly since it's done in outpatient surgical setting, the cost is a little more. But these diagnostic tests allow for a much more specific diagnosis and then a rapid onset to direct the actual treatment. So we've talked about back injuries, common back injuries, whether they're disc-related, bone or joint-related, muscular, nerve, or inflammatory. I don't want to necessarily ignore some of the other common injuries, but again, chronic pain, you can have injuries to the shoulder, wrist, hand, elbow, hip, knee, foot, ankle, really anywhere. All these injuries can be treated non-surgically, and what we do in our approach to treating chronic pain is to identify the structure involved, identify the pathophysiology of the injury, identify if there are any comorbidities present, take that information, obtain a very good history, really do our due diligence in doing a comprehensive pain assessment, knowing not only what caused the pain, what the mechanism of injury was, but again, looking at the pathophysiology, looking at the types of treatments that have been done in the past, taking all this into account, and then if we need to use diagnostic testing, using that, and then really focusing and directing our treatment to the particular area that's causing chronic pain. So in summary, we can't always remove the pain entirely, but our goal in treating chronic pain patients are to do the patient justice, to really all the things I've mentioned, to do our best to try to help the patient manage their pain, live a more productive life, improve their quality of life, and understanding the anatomic considerations and how that may direct our treatment, and hopefully add some value to the patient in so far as providing pain management and hopefully some pain relief. So what I've tried to do today is give you an understanding of not only pain management, but how the anatomy of the spine and anatomy of the body really comes into play and makes it very important in our treatment and evaluation. And I hope that you found that useful and the information helpful. Thank you very much.